Hello, good afternoon. Alena Skálová speaking. I have two consult cases and I hope that you will enjoy it. The first one is a probatory excision of a lesion which was located in the palate of 73-year-old female patient. And we can see squamous para-keratinizing epithelium of the oral mucosa and some kind of tumor, which I will show first in scanning magnification to show you general structure. So you can see that the epithelium on the surface is not dysplastic and it's even not infiltrated. And the tumor was removed in fragments, but still you can't see very well any invasive growth pattern or something like that. So we'll look at the high magnification at the moment, and we can see that the tumor is characterized by ductal and trabecular growth pattern, and at least in my opinion, the tumor is monophasic, relatively from done or composed of one cell type somehow. So what you can see here, maybe that's all what I can demonstrate. Some fibrocepta, a little bit tubular trabecular growth pattern. And why I'm demonstrating it, do you have the idea what it could be? Maybe here we are. Yeah, I think very nicely you can see fibrocepta with a little bit of myxoid transformation of the hyalinized matrix. So that's what we have. I can tell you some immuno. So we did PLAG1, HMGA2 is negative. CK14 is positive, S100 is positive. Yeah, SOX10 has been positive. And diagnosis of this case was an adenoid-cystic-carcinoma, and it came to me for the second. It's not for the second opinion. My diagnosis is canalicular adenoma. Yes, canalicular adenoma is a benign salivary gland tumor, which is typically seen in lip. However, it has been described also in palate. So this is canalicular adenoma, and my diagnosis, I supported it because of this discrepancy in two opinions of two pathologists. I did a lot of, or I have a help of molecular testing. So we have negative staining, negative fluorescence in situ hybridization for HMGA2, negative for PLAG1, and more importantly, negative for MYB. How do you pronounce it, Květo? MYB. MY. It's not MI, but MYB. And NFIB negative, MYB1 negative.
And how was BRAF?
BRAF was not done. BRAF was not done in this.
It should be positive.
Okay, very good. And there was no fusion on UST and GS. So for the purpose why I'm demonstrating it to show that it's not adenoid-cystic-carcinoma, and proliferative activity was very low, less than 5%. So a pitfall. Second case is more complicated.
We have a study just now being performed. We compare by methylation profiling this tumor together with syringocystadenoid papilliferum and apocrine of the skin, because we think that these tumors look similarly, all are BRAF mutated, and we might cluster on the same place. We will see. It's just being initiated a study of ours.
Very good. So I can add this BRAF staining. What if you want to, I can give the case to you. This is more difficult. It's a consult case, and you can see scanning magnification fragments. That's a probatory excision of the tumor of oropharynx in a 58-year-old male patient, and it was sent for second opinion from Germany. So what you can see are fragments of the tissue, which are partly covered by squamous epithelium. I'll show you higher magnification a little bit. So squamous epithelium, at least in my opinion, is not dysplastic. However, there is ulceration, of course, here and there. And then there is this infiltration composed of basaloid cells. Even better, it's seen in these fragments. There is a ulceration here, and these basaloid structures. I'll show you high magnification a little bit. We are out of the place, so it should be here. So high magnification shows some kind of structures which look like adenoid-cystic-carcinoma, but there is also squamous foci, like a little bit keratinization. So diagnosis is open, and there was some kind of diagnosis, and they did excision, and they sent also excision. So the excision shows more, and here we have the tumor. Again, first scanning magnification, you can appreciate that the tumor grows in lobules with a central necrotic foci. Immediately, I can say that it has very high proliferative activity. There is it's an oropharynx. There is this minor salivary gland, and I'm looking also to show you this this area. Again, you can appreciate this.
What was HPV?
Very good question. What was HPV? Definitely it was P16 positive, and we also received HPV typing, and it's a positive for HPV 16, not higher numbers, it's a 16 positive. So differential diagnosis seems to be between HPV-related sinonasal multiphenotypic carcinoma, but that's not so easy because it's oropharynx and it's human papillomavirus HPV 16, which is not the case of multiphenotypic sinonasal. So there are also features which point to something else, and in my opinion, it's either just the squamous non-keratinizing epithelium HPV related of oropharynx, and WHO classification has a subtype which is called basaloid HPV positive, and could be this one. But I'll show you a little bit something.
It's important because the
Yes.
tumor is easily curable. This one.
Yes, it's very important, and I'll show you a little bit of immuno to mix up us a little bit. So this is not cytokeratin, but it's a SOX10. So it's a diffusely SOX10 positive. Again, pointing a little bit to this adenoid-cystic stuff. We have a P16, I'm not showing you, but I'll show you P63, which is also quite interesting. So here we have a very nice positivity for P63, the same is for P40. some kind of palisading around the septa, some maybe a little bit, some tumor cells negative, but majority are very positive. Okay, and then the last immuno, which I would like to show you, not the two of them. This is P16. We are not interested, but we would like to see molecular, this MIB1. It's a very high high MIB1 key 67 index, so it's highly proliferative. But last but not least, I'll show you MYB immunostaining, which looks like this. And if we do not know that it's a surrogate marker which is not reliable, I believe that we would like to say yes, it's adenoid-cystic, but it's not. It's just positive. Immunohistochemistry is positive, but the molecular testing was negative. And now please show me the paper.
MIB is promiscuous.
It's promiscuous. I do not like it. So this is the paper which I found, and I believe that it's a nice example. But now let me see what I should do. Now my mouse is not working. Yes. I'd like to show you the next page, how to do it. Yes, like this. Okay, so I think this is quite similar case. I'll go up. They published one case, 2021, and they call it HPV-related carcinoma of oropharynx with squamous and adenoid-cystic-like features. One case report. And they say that it's something different, quite similar to our cases. You can see here, maybe a little bit. It's not so handy. Yes, adenoid-cystic carcinoma-like. To make it even more complicated, you know what we received from molecular lab, CILT gene mutation. So there is no fusion, there is a CILT gene mutation, and of course this HPV and negative staining for MIP and FIP and MIP fish is also negative. So my final diagnosis is squamous cell carcinoma of oropharynx with HPV related, looking like adenoid-cystic or with adenoid-cystic-like features.
Yeah, there is one new differential diagnosis now. It's a very new paper that appeared. Head and neck tumors, they are solid growing tumors. They look like transitional cell carcinoma-like. They are very often HPV positive, but they have FGFRS3.
Abbas. Yes, I know the paper. Abbas Aghaimi is the first.
And it's very important because FGFRS3 is can be targeted by biological
exactly.
treatment.
But this is different.
Different, but in differential diagnosis.
Yeah, good.
Mostly HPV 16, I guess, is the.
Yes. My point was that it looks like adenoid-cystic carcinoma or this sinonasal biphenotypical HPV related, but it's not. It's a more aggressive. It's not sinonasal, it's oropharynx, and it's different. It has different. This P16 has not been described in multiphenotypical sinonasal HPV. There are 33 and higher numbers. Yeah, so it's a different.
The morphology is essentially the same.
Yes, exactly, and that is I believe that I've really demonstrated that there is no dysplasia in the superficial epithelium, surface epithelium. So I believe that was an interesting case, and that's all from my side.
Good afternoon, everyone who is listening. This is Květa Michalová. I'll be showing you 4 cases. The first case is a very fresh case from our department. It was a 44 years old woman with adnexectomy. So this specimen comes from ovary. And what you see here, I think it's pretty straightforward what it is. It's endometriosis, endometrial cyst. I think most of us are very familiar with this. But there was not only endometriosis, but also other things in this biopsy. I have some circle, but I don't know where. Here. So here we have the lining of the endometrial cyst, which is also slightly atypical, but also this papillary lesion, which is architectonically quite similar to serous borderline tumor. But if we look closer to the lesion, and maybe the next specimen is better to better appreciate this lesion. It has this architecture, and it is slightly different from serous borderline tumor. This lesion is called Seromucinous borderline tumor, and it is typically composed of a mixture of Müllerian types epithelium. The name Seromucinous is not perfect for this lesion because there is not a perfect mixture of serous and mucinous glands. Most of them are serous and other differentiations, endometrioid and also mucinous. But also there is another quite typical feature for this lesion, which is edematous type of edematous stroma of the papillae. The first thing, and other thing is quite characteristic neutrophilic infiltration of the stroma and epithelium of the papillae, which is constantly present in these lesions. And also very typical for this lesion is to originate from endometriosis, from endometrial cysts, which is not the case of serous borderline tumors, which originates from serous cyst adenomas. So this is different from serous borderline tumor. And these are quite rare lesions, and they, as I said, they originate from endometriosis, and since they can transform into seromucinous borderline tumors, and when adenocarcinoma arises from these lesions, it is endometrioid adenocarcinoma. The diagnosis of seromucinous carcinoma is not accepted, and when it is carcinoma, it has endometrioid phenotype. So to summarize this, serous borderline tumor arises from endometriosis, and architectonically it is a copy of serous borderline tumor. Regarding cytology, there is a mixture of Müllerian type cells. It has edematous stroma with polymorphous inflammation, mostly neutrophiles, but there can be eosinophiles and other inflammatory cells. For example, here it's not very prominent in every case, but you can find it if you are focused on that.
There is one more thing, typical one. If you make higher magnification of these micropapillary cells cytologically, there are eosinophilic bleb-like cells in it. Make it very large magnification, and there are eosinophilic cells.
These hobnail cells?
Yeah, hobnail cells. And do you see them up? These hobnail cells are typically senescent cells that do not divide, and all cases are BRAF mutated. Yeah, these cells do not exist in any other tumor of the gynecological tract. These eosinophilic like cells. It's not. It's rare to find them like that. Yeah.
I counted them as a part of Müllerian type cells. Seromucinous borderline tumor of the ovary was the first case.
It's a sort of sign of malignancy, these cells,
Yeah. Second case comes from a 3-year-old boy. It has umbilical location, and there was a clinical symptom of umbilical discharge. And it is only this specimen. So here we have intact surface epithelium, and in the stroma, this is probably cause of the problem. This is quite simple biopsy. If you think about that, we have a young boy with umbilical discharge, and this cystic, or rather cystic small lesion close to the umbilicus. This is immunohistochemistry. I have to find the specimen. Sorry. Here. This is GATA3. So I think probably most of you already know the diagnosis. So GATA3 positive, and also another staining, CK7, and it will be positive as well. Somewhere. It was nicely positive when I had it in my microscope, but it was positive. Maybe this is a weird slide. I'll ask Patrick for the photo. So the diagnosis of this is umbilical-urachal sinus, which is an embryological remnant of urachus, which is an embryological structure here. Here at the upper part, you can see the embryological structure called urachus, which exists during embryological development. Under normal conditions, this hollow structure connects umbilicus to urinary bladder during intrauterine life, and then it becomes patent. But there can be some incapability or disorders of obliteration of urachus, which results in various disorders. And to summarize which disorders of urachus we can see, this picture is sufficient. So one of the disorder can be the patent urachus, so the general disability to obliterate the urachus. So it is then preserved throughout its whole way. Then the case which we saw, so it is a umbilical-urachal sinus, so a partially obliterated urachus, and there is a connection to the umbilicus causing umbilical discharge. Other option is to have partially cystically dilated urachus somewhere throughout the way of the embryological urachus, and the fourth option is vesico-urethral diverticulum. So the connection between urinary bladder and urachus. So the diagnosis of our case was umbilical-urachal sinus, benign condition, but you have to think about it to do the right diagnosis, because the sending department made 15 immunos to try to find out what this lesion is, but it's very simple if you think about that. You even do not need so many immunos. So we can move to other case, which is a testicular case, and we have a tumor of the testis. Here you can see the testicular germ cell tuberous, which are normal. Here is retrotestis, and close to retrotestis we have this spindle cell fascicularly arranged lesion tumor. If we go throughout the lesion, it is more or less the same everywhere. So there are fascicles of quite bland spindle cells. It is a pure tumor. There are no sex cord elements or other elements. It is completely differentiated into this spindle cell proliferation, and it is bland. Regarding immunohistochemistry, this lesion has very typical immunoprofile, and the diagnosis together with the morphology is based on this immunoprofile. This is actin S, smooth muscle actin, which is diffusely positive. And this is another diffusely positive staining, and it is S100. And if tumor like this, so the pure spindle cell bland tumor of the testis co-express S100 and smooth muscle actin, the diagnosis is myoid gonadal stromal tumor, which is gonadal stromal tumor with differentiation somewhere between smooth muscle tumors and between stromal tumors. It sometimes express S100 calretinin inhibin, so the sex cord markers, but it is not a constant feature. The only constant feature is co-expression of S100 and actin S, and I'll ask Patrick for the PDF.
And cytokeratin sometimes is positive.
Cytokeratins are quite frequently positive. In this case, there was a diffuse positivity of calretinin also, and cytokeratins, I don't know exactly, but they are quite frequently positive. Recently, there are quite new informations about this myoid gonadal stromal tumor of the testis, because because with NGS and other molecular genetic methods performed on various sex cord stromal tumors, it has been revealed that probably this myoid gonadal stromal tumor, which was included in WHO 2016 as a new entity, as an emerging entity, and 2022 as a new entity, might not be very unique, because its molecular genetic features is overlapping with other either pure gonadal stromal tumors, as are fibroma and chicoma tumors of the testis, and also with tumors containing not only gonadal stromal elements but also sex cord elements. So there is a rather larger group of these either purely or predominantly spindle cell testicular tumors, which all of them have overlapping molecular features, meaning they have multiple chromosomal abnormalities. And regarding morphology, these tumors can be either look like pure spindle cell tumors. This is an example of a myoid gonadal stromal tumor. This is also a stromal tumor with some mixture of sex cord elements. Or these can be tumors which are unclassified. This tumor, for example, looks from this picture in my eyes as gonadal stromal tumors, but it probably did not co-express S100 and actin S, and so it was unclassified gonadal stromal tumor. This is case classified as adult granulosa cell tumor of the testis. So probably with further genetical examinations on these tumors, there will be a rather larger group containing more tumors previously classified as distinct entities. But regarding myoid gonadal stromal tumor, it's quite important to know about this tumor because so far all of these tumors were behaving in benign fashion, which is not the case, for example, of adult granulosa cell tumor of the testis and other unclassified sex cord tumors. So if we have tumor which is purely a spindle cell, it is bland and it co-express actin and desmin, it might will have in the future different name, but we can tell the clinicians that this tumor will behave in a benign fashion. So this is the take-home message of the new research of this tumor. And my last case is also from the testis, and it was 70 years old man, and we have tumor like this. Here are some residual, rather atrophic testicular germ cell tubules, and the tumor itself is.
Oh, it's prostate, yeah.
Thank you. So, okay, it's a metastasis, it's also prostatic carcinoma, but there was you ruined my story. So, 70-year-old man. So, at first, it is improbable to have germ cell tumor at first in this age. Second option would be sex cord stromal tumor, which in this case there is a probability of some. It does not look typical for the sex cord tumor, but if this can be any kind of sex cord tumor, in my eyes, the option is it is sort of cerduliform differentiation. But this was negative for sex cord markers. But as Michal said already, this was a metastasis of prostate carcinoma, but it was not very straightforward because we performed since when we excluded all these options of primary testicular tumors, we then moved to the option that this could be metastatic carcinoma. And we had because this was my case and Michal's case a few years ago. So we had a discussion with clinicians and pathologists who sent us this case, and they told us this patient has prostate carcinoma few years ago, so there is a high probability this will be prostate carcinoma as well. So this is PSA, and it was completely negative. As well as was ERG. ERG is great marker of prostate carcinoma, but this prostate carcinoma will have to bear the fusion with ERG gene, which is the case of approximately 40 to 50% of prostate carcinoma. So since the negativity of the staining does not exclude a prostate carcinoma, but it was negative in this case, as well as was PAP-H. This is PAP-H, it was negative as well. And this is NK3X1, and it was hopefully, only focally, but definitely positive. And so together with the anamnesis of the patient, also regarding morphology, this is not very typical appearance of prostatic adenocarcinoma. Some types of prostate adenocarcinoma has a foam cell appearance, but it would not be the first option in your head when you look at this lesion. But when we review the original case from prostate, it looked exactly the same. So then it was clear that it was metastasis of prostate carcinoma. But before we had a discussion with these clinicians, we performed molecular analysis on this, and we couldn't arrive the right diagnosis. But as was said multiple times, sometimes the best immunos and the best molecular analysis is to have the anamnesis of the patient and to call the clinician, and you have the anamnesis right away. In general, metastatic tumors of the prostate of the testis are very rare, but when we have metastatic carcinoma, it is in most cases it is from prostate, and it is close to retrotestis. So sometimes it can resemble retrotestis adenocarcinoma, which is also a very rare lesion, and furthermore it is a diagnosis of exclusion. So before you make a diagnosis of retrotestis adenocarcinoma, it's always a good way to first exclude metastasis of the prostate. And that's all from my side.
I had one case 30 years ago like that, and I read in the literature, and practically all of us, when you have foam cell tumor of the testis, it's always metastatic from prostate, always. Remember that. It's like cystic metastasis on the leg being HPV positive, yeah?
In the era before immunohistochemistry, everything foamy in the prostate was called carcinoma. Okay, so foamy cell appearance of prostate glands is like guide to the cancer diagnosis. So Marián Švajdler here. I've got a couple of easy cases.
I get easy cases.
Couple not that easy cases. I will start with easy case. This is a pancreatic biopsy. So they had a lesion in the pancreatic tail, I believe, and as you can see already in this very low magnification, it's something blue there. So probably very, very highly malignant. And as you can see, you cannot see morphology of the cells. These cells are crushed, and it's because it's the feature of these cells. They are very easily to be crushed by the biopsy. So if you had, let's say, 2 or 3 immunos to give as a first try, maybe here morphology is better seen. So very high nucleocytoplasmic ratio, very high proliferative activity, many mitotic figures, maybe some necrosis present there. Okay, and the lesion was positive for cytokeratins. It's normal pancreas here, and at least some cells were weakly but positive for cytokeratins. And if you wish to see proliferation index, this is Ki67. Essentially all cells are positive. And if you wish to see neuroendocrine markers, synaptophysin, I believe was positive, but could be negative. Up to 4 or 5% of small cell neuroendocrine carcinomas may be negative for your neuroendocrine markers. So synaptophysin was positive, as was P16 staining, which is very good. We are in that INSM1 staining was, I believe, positive. Yeah, it's here. So it's small cell carcinoma. TTF1 in addition was positive, but this is not something very specific for pulmonary small cell carcinomas, because small cell carcinomas originating from many organs have essentially the same morphology, the same immunophenotype, including p53 staining and retinoblastoma protein loss. But this patient had a history of pulmonary small cell carcinoma, so this is metastasis to the pancreas. Okay, so always think about small cell carcinoma when you see something strange. My next case is peritoneal biopsy from duodenal tumor. And as you can see, they took mostly probably normal smooth muscle, but there are some islands or gland-like structures here. And we are in the duodenum, so any guesses? Not from these, okay. They also performed a biopsy from a paraduodenal lymph node, which was much more better. Okay. But the morphology is essentially the same. So this is very basic, easy. This acinar-like proliferation, maybe some, I'm not sure, salt and pepper chromatin, maybe not. But the region is positive for all neuroendocrine markers, and proliferation index was very low, below 1%. So this is grade 1, well-differentiated neuroendocrine tumor. Okay, easy one. Net grade 1. The duodenum. I've got another GIT case, or not GIT, it's gallbladder. It was sent in consultation. It was polypoid mass in the gallbladder, and it looked like this. Again, this is very basic pathology for residents mostly, but it was sent in consultation to one of my colleagues. You can see this gland-like polypoid proliferation, which is composed of not very atypical cells having this eosinophilic, sometimes ground glass cytoplasm. No or not many mitotic figures were present. Any diagnosis from our residents? So I believe I've got another slide. It's from the wall of the gallbladder next to the lesion. And it's gallbladder. It's gallbladder, and it shows signs of not very profound, but it's cholecystitis there. So this kind of lesion always occurs in inflamed organ, whether it's gallbladder or stomach or some other parts of GIT. And the lesion is called pyloric gland adenoma. It's basically H&E diagnosis, but if you wish to help yourself with immunohistochemistry, this epithelium will be negative for MAC2 staining, which is marker of intestinal differentiation. It will be positive for MAC6. It's the same positivity just like pyloric glands in the stomach. So you've got this nice diffuse MAC6 positivity, and it will be negative also for MAC5 AC, but in many cases you will have like mixed phenotype with intestinal and other types of epithelium present there. So in this case it looked quite pure pyloric gland. And regarding the dysplasia, it's hard to like grade these lesions, but if you will see high-grade dysplasia, it's 1 second diagnosis. Okay, so you are not like supposed to grade lesions like these. It's completely fine if you refer it as pyloric gland adenoma without high-grade dysplasia. Okay, and even if high-grade dysplasia is present, the prognosis of these pyloric gland adenomas is very, very good. There are essentially no progressive disease. I mean, sometimes they even may metastasize, but it's very, very, very rare. Okay, so, and in case it shows high-grade dysplasia, it's very difficult, like, to set border from in situ lesion to invasive carcinoma. But again, it's not that important because the prognosis is very, very good.
Excellent case. Well, what is the best marker? You spoke about MAC, so which one?
It will be
I believe that cytokeratin 20 and CDX2
this
is
will be
negative.
This will be negative, and if you wish to perform mucin staining, mucin 6 is positive.
Mucin
Okay,
6.
but you may have patchy mucin, or other mucins.
But it's quite common to see pyloric gland metaplasia or hyperplasia so it's the source for this kind of.
And one other marker, I forgot. This is beta-catenin staining because something between 80 to 100% of cases show beta-catenin mutation, and you can see these nice cytoplasmic, but most importantly, nuclear beta-catenin staining. Okay. So this is very nice example. So this was my warm up. My next case comes from the brain. They sent it as a probable metastatic disease, and the lady, older lady, had something in her thoracic cavity, and they performed repeatedly some cytology and biopsy specimens, and it was always not conclusive for the diagnosis. Even malignant mesothelioma was given as a differential diagnosis, and eventually she was found to have metastatic brain lesion, which was excised, and the lesion shows this epithelioid and almost rhabdoid-like features, very atypical looking cells with vesicular nuclei, prominent nucleoli, many mitotic figures. So it doesn't look like many primary tumors, and probably it's something melanoma-like maybe, yeah. But it shows.
It's okay for the patient.
It shows, yes, this is very good guess. It showed EMA staining quite diffuse, so it's probably epithelial. And we had this history of thoracic tumor, so we performed SMARC A4 staining. This is the result. You can see positivity in the background cells, negativity, loss of expression in tumor cells, and even some TTF1 expression. It was not that strong. I believe it wants to be positive for TTF1. So our final diagnosis was it could be either poorly differentiated / undifferentiated pulmonary carcinoma with SMARC A4 loss of expression, or so-called undifferentiated SMARC A4 deficient thoracic neoplasm. So these days we can diagnose these tumors much more frequently because it's still a new entity. It was considered to be quite rare, but we just in few months we have seen maybe 4 or 5 cases. So, and it's not a consult case; it's in-house case. The prognosis of this kind of tumor is very, very bad. Median survival time is something about 6 months, and this lady is already dead. Okay, so they were not able to give any therapy before we were able to make a diagnosis, unfortunately.
It could be checkpoint inhibitors, maybe.
Yeah, maybe. What we can do as a pathologist, we can do some genetic testing, and in case the tumor shows something targetable, it's very similar to pulmonary carcinoma. They can give like targeted treatment, but still we don't know much about the entity, and the current state of knowledge is that this is very highly malignant, very aggressive type of cancer, and we saw patients dying in 1 or 2 months after the diagnosis. My another case is another consult case. This is older male with biopsy from large bowel tumor, and there is nothing interesting in the mucosa, but there is some kind of smooth muscle proliferation, which at the first sight looks like mucosal prolapse. Yeah. But if you go to higher magnification, you start seeing some atypias in these cells. So the biopsy is a little bit crushed, but we fortunately had another piece of tissue, which is quite more obvious that it's a tumorous proliferation. So just by H&E, small muscle proliferation, it was of course confirmed by immunohistochemistry. It was positive for desmin, smooth muscle actin, H. Caldesman, and there are atypias, a lot of mitotic figures, including atypical mitotic figures. So this is an example of nowadays very rare leiomyosarcoma of GIT. In the bowel, large bowel, still rectal or sigmoid tumors are still more frequent compared to GISTs. Okay, so we are dealing with smooth muscle neoplasm, malignant looking. In the rectal area, leiomyosarcoma will be more frequent diagnosis compared to GIST. But otherwise, all GIT tract, GIST is far more common. So they had correct diagnosis at the referring lab, and it was just like sent for confirmation of the diagnosis. My next case is very interesting one. This is, let's say, middle-aged male patient with a lesion in his eye. So it's intraocular tumor, and just before looking into the microscope, you will say it must be melanoma, right? And still, just by looking at the biopsy, this very low magnification, it's spindly. It must be melanoma, but it was sent in consultation because melanoma markers were negative. And clinicians sent the case with the diagnosis of probable intraocular astrocytoma. So I've repeated melanoma markers and added some because they had only, I believe, 2 or 3. There is also some necrosis there. So after we rolled out melanoma and glioma, because GFAP was focally positive, but GFAP may have cross-reactivity with epithelial lesions. There is cross-reactivity between GFAP and cytokeratins. So I performed Claudin 4 and MOC 31 staining. Both were positive, so the lesion must be epithelial. And then I started to think what kind of epithelial neoplasm it could be. Intraocularly, we may have adenomas and adenocarcinomas, but these morphologically are completely different. And I performed several stains, but this was the most helpful, and it's P4T. So the lesion is diffusely P4T positive. There was also P63 positivity and focal cytokeratin 5/6 positivity and diffuse P16 positivity. So it must be basaloid squamous cell carcinoma metastatic to the eye. I also performed HPV testing, which came negative. Okay, so P16 positivity in a metastatic squamous cell carcinoma does not tell you it's HPV related, because, for example, 1/2 of pulmonary squamous cell carcinomas are P16 diffusely positive and HPV negative. So, or urinary bladder carcinomas may have P16 positivity and are almost always HPV negative. So this is basaloid squamous cell carcinoma metastatic to eye, and it's up to clinicians to find the origin of the lesion. And yeah, my last case is I don't know the diagnosis. Again, it's a consult. It comes from the brain, and the slides are not very good. We'll try to find.
It's brain?
It's brain lesion, yeah. Maybe here. Is this essentially small round blue cell tumor in an elderly adult patient? And they performed many immunohistochemical stains, and only PRAME immuno was positive, but all melanoma markers were negative. Regarding PRAME antibody, it shouldn't be used as a melanoma marker. Okay, you can use it only in your differential diagnosis between benign and malignant melanocytic lesions. Otherwise, you are in trouble. Okay, so PRAME will be positive in many malignancies all over the body. So it's not melanoma marker. And again, I performed many stainings. Almost everything was negative, and only SMARC-A4 was lost. See, endothelium positive and loss of expression of the markers. It's a female patient. So my differential, we also perform methylation profiling. CNS brain tumor classifier came with no result. Sarcoma classifier came with no result. This high-tech classifier suggested diagnosis of metastatic lung adenocarcinoma, which again, together with SMARCA4 loss of expression, kind of makes sense, but they have to correlate it with radiological findings. The other possibility is atypical teratoid rhabdoid tumor, which in about 1 or 2% of cases shows SMARCA4 loss of expression instead of SMARCB1. But it's adult patient, not a child, and again, CNS brain classifier came negative for this kind of diagnosis. And my third differential diagnostic option is metastatic small cell carcinoma, hypercalcemic type from the ovary. Again, they should correlate with the clinics. And it was negative for cytokeratins. I will expect at least some focal positivity for ovarian tumor. So I don't know what it is. Okay. So that's it from my side.
I have one case just to show you because I want to send the slides to Dr. Bradova and it lies on my table already for a month. So this amazing case, only one will be presented here. And Michael Senior. It's nasal lesion. It's nasal lesion, and all the peripheral parts of the lesion is formed by, you see, Seromucinous hamartoma. Like here, you see. But the central part of the lesion has this tumor. It means that it's some tumor probably arising from Seromucinous hamartoma. And from HNE I could not say what it might be, even if I should know it. We did genetics and it got what is the car?
So
Pyloric fusion, which is typical for cribriform carcinoma of the nasal lesion, and it's final proof another lesion that arises from Seromucinous hamartoma. I have a very nice slide, stained lysozyme, which is a marker, very good marker of Seromucinous hamartoma. But you see that even here, even part of the tumor is lysozyme positive. That is from the transitions between Seromucinous hamartoma and the tumor here. So that I think this is Seromucinous hamartoma giving rise to cribriform carcinoma of minor salivary glands. In the middle, you see atypical glandular formation, that these cells that are between the adenocarcinoma and Seromucinous hamartoma. So that is the first case I ever saw the origin of the tumor. Without genetics, I would be sure that it's this tumor. And this tumor, cribriform carcinoma, we described for the first time 28 years ago, and for 20 years it was a huge fight whether the tumor is part of polymorphous adenocarcinoma of minor salivary gland or whether it is self-standing tumor. This tumor very often metastasized during the diagnosis, which is very different from polymorphous low grade. It is radiosensitive, practically patients never dying of it. And final proof that it's self-standing tumor is methylation profiling. It is cluster different from polymorphous adenocarcinoma. So it's really a tumor for which we fought. We were fighting for the entity for 27 years. And I don't want to name out all the world pathologists that were telling that we were mistaken. Now they stopped discussing when we presented this special entity.
I would add something. I agree completely with Michal, but the fight continues. Don't think that the fight is end at the end. Just now I have a paper where they mix it together for review.
Because they didn't read it.
They should read. They should know.
Okay. Let's take pizza. Thanks for attention.